Good morning, and thank you for the kind introduction today. Today I'd like to talk about a different approach to infectious disease, and that's via the use of innate defense regulators, which offer a broad spectrum and host-directed approach for antibiotic-resistant disease. Before I begin today, I must make the obligatory forward-looking statements, as Sologenics is a public company. But let's begin with discussing first what we mean by saying innate immunity. Obviously, everyone is very familiar with the adaptive immune system with its T cells and its antibody responses, but the innate immune system is a very necessary precursor to the adaptive immune system. And it's really characterized by its ability to respond very rapidly to any infection through pre-programmed responses. So these responses don't have to be learned over time, but that also means that they're somewhat non-specific. The innate immune system involves both circulating and tissue-resident cells, and that means it's particularly active at all interfaces between the organism and the outside world. So think the mouth, the gastrointestinal tract, the lung, the skin, for example. One of the most interesting things about the innate immune system is that it's an incredibly ancient and conserved system. And yet, for years, we had always thought that it was also a somewhat crude system, and that we couldn't differentiate the inflammation, which is so much associated with innate immunity, from anything else that the innate immune system did. However, more recently, in the last 15 years, it's become apparent that we can, in fact, separate these pathways, especially at the intracellular level, and it's this precise finding that the innate defense regulators really look to exploit. And finally, as should be obvious from the mechanism of action, of course, antibiotics will act in tandem with the innate immune system as they do every day, and would obviously do as well once we enhance the innate immune response. So the innate defense regulators are a unique approach to attempts to modulating the innate immune system. As I mentioned earlier, the innate immune system achieves its very rapid response through having pre-programmed responses, and the way it achieves this is through having a lot of what are called innate immune receptors, such as the toll-like receptors or the nods, that are able to detect many of the molecular patterns that pathogens share and also that damaged cells share, so that the innate immune system actually responds both in the case of host damage as well as in the case of pathogen infection of the host. Now, previous attempts to modulate the innate immune system really looked at the level of these receptors and tried to modulate the receptor response, which was sort of the first step in the innate immune cascade. But more recently, we've really begun to understand that the innate immune system, while it has many receptors, actually has intracellular convergence points in the signaling pathways downstream of that. So that if you really want to alter the response of the innate immune system in character instead of just in terms of size or intensity, then you really need to look at these downstream signaling pathways. So this, of course, is the approach that the innate defense regulators take, and today I'm going to mostly speak about our lead clinical candidate, which is known as Dusquetide. And Dusquetide binds directly to an adapter protein in one of these intracellular nodes of signaling called P62 or sequestosome 1. And binding with this adapter actually changes the balance of the downstream signaling pathways of the innate immune system. So it enhances selective effector cell recruitment, which leads to wound debridement and healing, as well as pathogen killing and clearance, but at the same time it also down modulates and controls inflammation. And that inflammation control is really garnered not by targeting any one cytokine or chemokine, but rather by changing the underlying inflammatory state of the system. And you'll see that reflected in a lot of different signaling markers. So for instance, we will get IL-1RA, which is an anti-inflammatory signaling molecule, going up, while IL-1 beta will go down. We'll see TNFR2, again, an anti-inflammatory receptor, going up, and TNF-alpha going down. So again, this is what makes the innate defense regulator approach unique. Previous attempts, thinking of things like TLR agonists, for example, really try to just turn on the innate immune system more by interacting with the receptors. But of course, that couldn't differentiate between the inflammatory response. and the anti-infective response, for example. So to take a somewhat deeper look at this, as I mentioned, Dusquetide interacts directly with P62 or sequestosome 1. And the interesting thing about this protein is that it's a scaffold protein. It doesn't have enzymatic activity. Rather, what it's responsible for is bringing all the players to the game. Dusquetide actually specifically interacts with one domain on P62, known as the ZZ domain, and specifically alters protein-protein complexes that occur at that domain, such as with the RIP1 kinase protein. This results, for example, in P38 phosphorylation and turning on the CEBP beta transcription factor, but does not in fact alter interactions that occur with other P62 domains that, for instance, might control the NF-kappa B transcription factor. And that actually explains the degree of the selectivity we see in terms of the resulting modulation of pathways. Clearly, we don't turn off NF-kappa B, but we also don't turn it on more, and that's important as most people would recognize NF-kappa B as an inflammatory signaling transcription factor. So as a result of the innate defense regulators acting downstream of these pre-programmed responses, innate defense regulators work as long as the innate defense system has been turned on, and it really doesn't matter how the innate defense system is turned on. This means that the innate defense regulators intrinsically have broad spectrum activity. So they'll improve survival and bacterial clearance, and they'll do so irrespective of what the actual pathogen is. So the pathogen can be gram-negative or gram-positive, intracellular or extracellular, and antibiotic-sensitive or antibiotic-resistant. Moreover, as I mentioned earlier, the innate immune system is effective at a lot of different anatomical locations throughout the host or the host organism, and this really contributes again to its broad spectrum activity. And more importantly, perhaps, it's not the innate defense regulator that has to be targeted to the infection, because the innate immune system already has very unique targeting systems in place. The innate defense regulators are also active in immune-compromised animals. Again, this comes back to the fact that the innate immune system is not just about circulating cells, but also about tissue-resident cells, and also aids in the resolution of tissue damage, since tissue damage is also capable of turning on the innate immune system. And finally, as I've commented on earlier, this allows the innate immune system to also modulate inflammation. Most importantly, perhaps for the discussion we're having today, this means that the innate immune system, an enhanced innate immune response, will target bacterial infection in a complementary way to antibiotics and therefore enhance antibiotic action. So to start with, let's just think about what this means from an anti-infective perspective. One of the most important things to understand about the innate defense regulators is that they improve survival after infection, even in the therapeutic context and even in immune-compromised animals. And we have two examples of this here. On the left-hand side, we have a gram-positive antibiotic-resistant Bacteremia caused by methicillin-resistant Staph aureus. And on the right-hand side, we have a gram-negative leukopenic septicemia, which is caused by Pseudomonas aeruginosa in leukopenic or neutropenic rats. So the important thing to recognize here is that therapeutic administration has previously been problematic for innate immune modulators, and that's because these modulators really try to just turn on the innate immune system more by operating at the level of the receptors, for example. But the consequences of this is that they also turned on inflammation more, and that was deleterious in a therapeutic context. This, of course, is not an issue with the innate defense regulators, because the innate defense regulators work downstream of the innate immune receptors. As I mentioned earlier, again, because the mechanisms of action are obviously distinct, the innate defense regulators also complement antibiotic action. And in fact, in this example, which is a lung infection with the gram-negative and antibiotic-resistant Burkholderia pseudomallei, we actually see synergistic action between Dusquetide and doxycycline over and above either doxycycline or Dusquetide operating by itself. This is particularly interesting because the Burkholderia pseudomallei is also a biodefense agent a category threat level of B, and is known to have very high intrinsic antibiotic resistance, sort of generating both proof of principle activities of the innate defense regulators. Now, one of the questions, of course, is how do the innate defense regulators allow enhanced survival in these models, and can they possibly actually also contribute to the clearance of the bacteria themselves? And the answer to this, of course, is yes, as we see here on this slide. So on the left-hand side, we have a peritoneal infection. So this is a mouse whose peritoneal cavity has been infected with Staph aureus, and we've looked at what treatment, or sorry, no treatment or treatment with saline versus Dusquetide treatment does to the bacterial counts in the peritoneal cavity. Here we see that Dusquetide significantly lowers those bacterial counts to below detection levels in the majority of cases. On the right-hand side, we see a methicillin-resistant thigh infection model. In this case, we can see that while vancomycin at 30 and 100 mg per kg definitely reduce bacterial counts, addition of Dusquetide on top of the vancomycin at 30 mg per kg also achieves an enhanced reduction of the bacterial counts, demonstrating again that the innate defense regulators are both complementary to antibiotic action and are also able to reduce bacterial counts. One of the things we looked on very early on, of course, is this idea about how much of this effect is really driven by the innate immune system as opposed to the adaptive immune system. So this was an early bacteremia study, again done with the antibiotic-resistant gram-positive MRSA, but it was done in nude mice, that is, mice lacking T cells. And here again, we found a very similar dose-response relationship to that we see in immune-competent mice. So really, the circulating adaptive immune system is not consequential to the action of the innate defense regulators. One of the obvious questions is how, if we are not directly killing the bacteria, and incubation of bacteria directly with the innate defense regulators reveals that they neither kill the bacteria nor are they bacteriostatic. Given this information, how is it that we're actually reducing the bacterial counts? And here we come back to that same peritoneal infection model, and if we look in that peritoneal cavity and ask what's different, we can see that there's been a significant difference in the recruitment of the effector cell macrophages to the peritoneal cavity. Of course, the macrophages can aid in clearing the infection when they're present, and this increased macrophage population is actually present regardless of whether the Dusquetide was given directly into the IP cavity or was given systemically. This comes back to my previous point that the innate defense regulator doesn't have to be targeted to the site of infection. The innate immune system already has multiple mechanisms in place to target infection, and what the innate defense regulators are doing is simply bolstering that response. But the specificity of targeting remains with the existing mechanisms in the innate immune system. So then, of course, the question becomes, how do the macrophages get to that site, to that peritoneal cavity? And independent tests have demonstrated that the innate defense regulators in and of themselves are not chemokines, but rather what we find at earlier points in the development of the infection after treatment with Dusquetide is that we enhance other chemokine signaling moieties that are expressed in the peritoneal cavity and are potentially responsible for recruiting the macrophages to the site of infection. So for instance, we see a statistically significant increase in RANTES and a trended increase in IP10 levels. One of the other things that's obviously also of interest in infectious disease is inflammation. Obviously, it's necessary in order to prevent and in the early stages of treating an infection, but later on can become strongly deleterious. So we ask the question, obviously, what happens later on in the infection? Again, this same peritoneal infection model on the left-hand side, we can see not only have the bacteria being cleared, as I showed you earlier, but also the TNF-alpha levels in that peritoneal cavity are dramatically reduced in the presence of Dusquetide. Of course, as I mentioned earlier, the treatment, the Dusquetide control of inflammation isn't just limited to a single TNF-alpha, for example, but is actually a broad change in state. And we can see this on the right-hand side. Here we've got a sterile inflammatory trigger, which is endotoxin being given into the lung of these mice. And we're finding that in the mice, the anti-inflammatory signaling moiety IL-1RA is increased in that bowel fluid. So one of the most interesting things about the innate defense regulators is that they bolster the innate immune system, and the innate immune system is really a very intricate set of signaling pathways in which intercellular communication is extremely important. And when we saw these early results where the chemokine levels came up and the macrophages came in to the site of infection, and yet the IDRs were not chemokines themselves, we asked the question, what could be mediating these effects what could be mediating the effects that call the macrophages to the site of infection? And so some of the early studies we did was we looked at very immune active tissues, like for instance spleen cells. And this is a little bit of an adoptive transfer experiment. It's a bit complicated, so I'll just walk through it step by step. So to start with, we excise spleen cells from mice, and we treat those spleen cells with innate defense regulators, as well as triggering their innate immune responses with endotoxin. We then incubate those cells for 24 hours. Now, one of the things I haven't mentioned to this point is that the innate defense regulators are actually peptide drugs. They're composed of primarily all L amino acids, and they're quite short, so 5 or 6 amino acids long in general. So clearly they're going to have very short half-lives. We'll all appreciate the mean residence time in circulating blood, for instance, in humans is less than 10 minutes. So clearly, after 24 hours incubation with primary spleen cells, there are no innate defense regulators left in the mix. They've all been metabolized into the constituent amino acids. However, when we take that conditioned media from those spleen cells and put them on a macrophage cell line, and raw cells are a mouse macrophage-like cell line, we actually see an altered response of those raw cells in terms of the cytokines and chemokines they'll produce. So on the bottom left here, we can see that we have Dusquetide, again, treatment versus no IDR or saline. And we see that the presence of the Dusquetide results in decreased IL-6 signaling, so a less inflammatory state for the macrophages. When we go to an analog that has very little binding ability to P62, this effect disappears. And we go to another analog that, although not a drug candidate, has enhanced P62 binding, we see that this response gets stronger. A similar trend is seen with the TNF-alpha results. So again, Dusquetide lowers the TNF-alpha levels. If the compound doesn't bind to P62, this doesn't occur. And if the compound binds more strongly to P62, there's potentially less TNF-alpha released. So the interesting thing here is that the responsiveness we're seeing way downstream from the raw cells, who never actually see these compounds directly, is correlating with the ability of those compounds to bind to P62 as we measure it in our direct binding assay. So again, this emphasizes the fact that there's a lot of intracellular communication in the innate immune system, and that the tissue response is as important as the circulating cell response. And this explains how the innate defense regulators can be as active in immune compromised animals, that is, animals whose leukopenic cells have been largely obliterated from circulation, as they are in fully immune competent animals. So I mentioned previously that we had seen anti-inflammatory effects with the innate defense regulators in mice, and in our safety pharmacology studies, we were able to recapitulate these anti-inflammatory findings in the non-human primate as well. In fact, in the non-human primate, because we're able to dose significantly higher due to the size of the animals, we actually found that there was a nonlinear dose response occurring in the anti-inflammatory effect. Now, this was not entirely unexpected given the mechanism of action of the innate defense regulators, where they're really interacting and rebalancing multiple pathways. there's a known history in immunology of this idea of rebalancing or competing pathways, and that resulting in a non-linear dose-response relationship, and that is exactly what we observed here. This was quite an interesting finding because it reminded us again that the innate immune system can address multiple pathologies and works in any domain in which the innate immune system is turned on. And so we decided to actually look at this in a slightly different context by evaluating the effect maybe in the context of a more anti-inflammatory and tissue damage perspective. In oral mucositis, the innate immune system is a key player in the disease pathogenesis. So oral mucositis is a really debilitating side effect that occurs in any sort of chemotherapy or radiation therapy regimen directed at tumor treatment. And what happens is that the oral mucosa and also the mucosa throughout the gastrointestinal tract becomes very fragile, can become ulcerated and susceptible to infection. And this can cause not only the consequent damage to the tissue specifically, but also a really debilitating pain. And in fact, the pain can be so severe that the patients may refuse to eat and or drink. This ultimately can lead to dehydration, to malnutrition, to increased hospital admissions, and to a higher risk for infection. So it's a very serious side effect, and in fact it can be so severe that patients will actually elect to stop their life-saving cancer treatment because the side effect itself is too unbearable. So initially, oral mucositis was thought to be caused by the chemoradiation damage directly to the normal tissue, and over time, of course, chemoradiation therapies have become more and more normal tissue sparing with advancements that have been made in the space. But repeated attempts to sort of treat this as the only cause of the oral mucositis has ultimately led to failures in clinical trials. And what's become understood more recently is that although there is absolutely, of course, damage done not only to the tumor cells but some of the surrounding normal tissue, importantly, these damaged cells, whether tumor cells or normal cells, release damage-associated molecular patterns, which then triggers a response in the innate immune system. This innate immune system then exacerbates the damage to the underlying tissue, resulting in more ulceration. And this is why in oral mucositis you actually see the peak in the disease progression days after the chemoradiation insult has occurred. And that's because there's this entrainment of an exacerbating innate immune response that causes the damage to worsen over the first period. Once, of course, this ulceration has occurred, not only are these ulcers extremely painful, but they're also, of course, a portal of entry for systemic infection, which is also life-threatening for these patients. And ultimately, of course, the innate immune system is also important in promoting the tissue healing that causes these ulcers to ultimately disappear and be completely reversed, albeit after many days of pain and potential consequences. The exact duration and onset of oral mucositis really varies with the chemoradiation regimen that's being utilized in the patients, but in all cases it's considered one of the most severe side effects of tumor treatment. So the innate defense regulators, if you think about it, are very well suited to this indication. They obviously will not do anything to protect the cells from direct death caused by chemotherapy and radiation. And this is important in this indication because we certainly wouldn't want to be protecting the tumor. However, at every step subsequent to that initial damage, the innate defense regulators can mitigate many of the deleterious effects of the innate immune response. So they can dampen these inflammatory signaling markers, which would result in the tissue damage getting worse. They can also help to offset some of the infection, and of course may also go on to accelerate the tissue healing to help resolve the ulcers directly. So understanding the pathogenesis of oral mucositis, we decided to look at how these innate defense regulators would perform in both the context of radiation-induced mucositis as well as chemotherapy-induced mucositis. So on the left-hand side, we see an oral mucositis model. This was actually conducted in hamsters. And we find that the duration of oral mucositis is reduced by about 50% in the presence of Dusquetide treatment. So again, all of those secondary effects downstream of the chemoradiation therapy have been successfully mitigated by the treatment with the innate defense regulators. And on the right-hand side, we see again that this effect is highly systemic. So here, with chemotherapy-induced mucositis, the chemotherapy causes damage not just to the oral cavity, but also throughout the gastrointestinal tract as well. And here again, we see a 50% reduction in the duration of oral mucositis, as well as about a 50% reduction in the severity of damage in the colon. One of the other interesting effects of the innate defense regulators is that they trigger a change in the innate immune system. And as we saw clearly with the earlier example with the spleen cells, they don't have to be present in the mixture for the effect itself to be enduring. This was also observed in both the infection models and in the oral mucositis models. So for instance, in the infection models, we could treat up to 5 days prior to infection and still have an effect, despite the fact that these small peptides were undoubtedly completely metabolized to their constituent amino acids within hours of administration. Moreover, when we tried administering more Dusquetide within a short period of time under the premise that more is better, we found in fact that additional administration of the Dusquetide did not in fact enhance any responses unless the administration was spaced out by at least 48 to 72 hours. So simply giving more within the first 24-hour period, for example, had very little added or no added benefit. This is also seen in the oral mucositis models, where it was a bit easier to study because the oral mucositis is a more chronic condition, so easier to track over time and easier to observe the effects of multiple doses on. And here again, we found that treatment every 3rd day during radiation was optimal. So at this point, having demonstrated that the innate defense regulators operated both downstream of pathogen-associated signaling as well as damage-associated signaling, the time had come, of course, to ask the question, well, it's fine if all this happens in small furry creatures, how well does it translate to the clinical setting? We all know there's many things we can treat in mice that don't quite work out as well in humans. Of course, those of us who had worked on the program from the outset really felt that the innate defense regulators should translate very well to the clinic, and our arguments for that, of course, were that the innate immune system is present in all animals and is very highly conserved across all orders of mammals. And not only is the innate immune system conserved, but the target protein itself is highly conserved, with 91% sequence identity between mouse and human and 99% sequence identity between orangutan and human. But clearly, of course, the proof here is in the data. So to date, we have completed both a phase 1 study in 84 healthy human volunteers and a phase 2 study in 111 head and neck cancer patients at risk of severe oral mucositis. And to steal a bit of my own thunder, I will say that we saw complete concordance between the non-clinical and the clinical findings. But let's look at what that actually looks like. So in our phase 1 study, we were clearly looking at the safety and tolerability of different ascending doses of Dusquetide administered either as a single dose or as 7 daily doses. And what we found was that the drug was very well tolerated. There was no dose-limiting toxicity identified. There was no maximum tolerated dose. And we stopped at our highest dose of 8 mg per kg only because we couldn't see any commercial reason for why we would exceed that dosing in our clinical development plan. However, one of the other things we looked at was we tried to assess what the inflammatory state of the individuals receiving the different doses of Dusquetide were. And to do that, we took blood from the healthy volunteers and stimulated their blood with endotoxin to get a read on how their cells would respond to an inflammatory stimulus after having been exposed to Dusquetide. And clearly, we would expect an anti-inflammatory response in the context of all of our preclinical studies. And this indeed is what we saw. So on the left-hand side, you can see what happens when we withdrew the blood 1 hour post-dosing and stimulated it with LPS for 4 hours. And here we divided the patients into two groups. Those receiving what we called a low dose of Dusquetide between 0.15 and 2 mg per kg, and those receiving a high dose. And you can see clearly that that nonlinear dose response we had started to see in our non-human primates was recapitulated here. Also of interest, when we withdrew the blood 96 hours after the last time that patients received a dose of Dusquetide, this same relationship was still observable, again recapitulating that extended pharmacodynamic effect we had referred to earlier. So on the basis of these results, we move forward into a phase 2 study, and we clearly wanted to study both the effects of low-dose Dusquetide treatment, as shown by the 0.15 to 2 mg per kg group, as well as high-dose Dusquetide treatment. So then we proceeded into a phase 2 study, as I mentioned earlier, in head and neck cancer patients. Now, head and neck cancer patients receive chemoradiation therapy for 7 weeks, and for 5 days a week, for 7 weeks, they receive daily radiation insults. And they also receive cisplatin chemotherapy, which is a cytotoxic chemotherapy regimen. So both forms of tissue damage are occurring with these patients throughout a protracted period of time. We treated with Dusquetide twice weekly at 1.5 and 6 mg per kg, and again we saw our best result at the 1.5 mg per kg level, as shown here. So on the left-hand side, you can see that the median duration of severe oral mucositis was decreased from 18 days to 9 days. This is extremely important because 18 days without eating and or drinking will be highly significant to the patient's ability to withstand and recover from the underlying cancer chemotherapy. And in addition, we also identified a patient population, or a number of patient populations actually, that were at high risk of severe oral mucositis. When these patient populations were isolated and found to have even higher durations of severe oral mucositis, 30 days median duration. Again, treatment of Dusquetide in this subgroup reduced the median duration down to 10 days. So again, this very much recapitulated the results we had seen in our preclinical studies. Finally, and from the context of what we're discussing today, one of the most interesting findings was in the anti-infective space. So clearly these patients are receiving chemoradiation therapy, they have significant oral tumors, they're at very high risk for infection. And we recorded infections as a monitored adverse event in this study. Now, it really didn't matter what the infection was caused by, nor did it matter what concomitant treatment the patients were receiving. So this was a very heterogeneous patient population from the point of view of most infectious disease studies. Nonetheless, treatment with Dusquetide clearly resulted in a statistically significant reduction in the number of infections occurring in these patients. And moreover, when we focused that evaluation to the non-fungal, by which we mean bacterial infections, we found that this same trend still held. So from the infectious disease perspective, we can see again that we've generated a proof of principle data in this phase 2 study, clearly demonstrating that the anti-infective characteristics we observed in the animal studies also carried forward into the human population. So from the infectious disease perspective, the innate defense regulators offer a number of advantages. Firstly, their broad spectrum activity means that you would not be required to positively identify a pathogen before initiating treatment, that the treatment would be effective irrespective of the degree of antibiotic resistance that a given pathogen has, and moreover that the compound will work in at-risk populations, including immune-compromised populations, since clearly the head and neck cancer population is a fairly fragile population as well. Moreover, the innate defense regulators can operate in tandem with antibiotics, so they can be combined with standard of care antibiotic therapy, and we've specifically tested for interference with most major antibiotic classes and demonstrate that there is none. Of course, we wouldn't have expected interference because, again, these compounds are not metabolized by the liver or kidney, but rather by blood and tissue peptidases, meaning that there is no likely interference with other co-administered drugs. So from the big picture then, the IDR program is fairly advanced with CGMP quality drug product available. Clearly, we've completed pharmacokinetics and non-clinical toxicology studies, although we haven't spoken to them in detail today, as well as having completed both phase 1 healthy volunteer studies and a phase 2 clinical study in oral mucositis. In fact, Sologenics is continuing to pursue the innate defense regulators specifically in more oral mucositis with a pivotal phase 3 study initiated this year. There's also a portfolio of IDR analogs, and we do of course have the co-crystal structure solved for Dusquetide in its binding site, so we have a very well understood structure-activity relationship as well. In conclusion, I hope I've convinced you today that the innate defense regulators represent a new class of anti-infective compounds that have a unique mechanism of action with correspondingly important benefits for the treatment of clinical infectious disease. The IDRs may significantly enhance antibiotic efficacy, and they should not increase resistance since they clearly do not target the bacteria directly. And finally, because the innate defense regulators operate via the innate immune system, they're independent of what the actual bacterial pathogen characteristics are. This results in broad spectrum activity, as well as an ability to target both tissue-mediated and circulating innate immune responses. The viability of the innate defense regulator approach to clinical infection has been demonstrated by the high degree of clinical translation we observed in our recent phase 2 clinical study. Finally, I'd just like to take a moment to acknowledge some of the collaborators we've worked with over the years, and of course the funding agencies that have provided some support for this work through the National Institutes of Health.